Okay, hi everybody. My name is Dr. Ravindra Mehta, and we welcome everybody to this interesting webinar in COVID times. I'll just be sharing my screen now and then I will continue our discussion. So, the topic of today's webinar is Current and Future Dynamics of COVID-19, appropriately titled because it's not about what has already happened, but where are we now and where are we headed. The reason COVID-19 continues to have interest is because, interestingly, it's playing this hop, skip, and jump game where it tends to die out in one part of the world and then rear its ugly head, if I can use that word, in some other part of the world. And so we have typically and futuristically a panel which is geared up towards looking at all these aspects. This is a true international panel we have today. People from 4 continents. We have Dr. Barry Zingman from the USA. I'll be introducing my panelists very shortly in detail. Dr. Asia Talaiva from Russia, Dr. Luciana Giusti from Brazil, and Dr. Alexandre Marini Isola from Brazil also. I hope I did better justice to your names this time, ladies and gentlemen. Thank you so much. The smiles speak for themselves. And I am Ravi Mehta, and I'll be briefly introducing everybody. Most of these names are well known because they have left a mark in COVID times as well as are accomplished researchers. In the interest of time, I'll keep it brief because I'm sure you want to listen to what they have to say as much as who they are. So Dr. Barry Zingman comes with a very august background of infectious disease with a background of AIDS jumping into COVID-19. I'm from New York, Albert Einstein, close to me also because I lived in Brooklyn for many years and he's at the opposite end, at the north end of the city, and so brings very fond memories. His recent accomplishments include a lot of work in remdesivir and publications to just start the beginning of what he has done. Shifting gears, we have Dr. Asia Talaiva, who comes to us with experience in cardiology from, again, a very august background, accomplished institutions, a lot of work done, and we will be leaning on her for a lot of important issues in this particular field. She's also well published both nationally and internationally. Dr. Luciana Giusti has got an infectious disease background. Again, so the same background as Dr. Barry Zingman, and she comes from Brazil, which has also been both a hub of COVID-19. Apologies for that word, and it's just like us, I guess, in India. At the same time, a lot of important work has come from Brazil, lessons, dynamics, and many things which have been very important to COVID-19. Dr. Alexandre Marini Isola also comes from Brazil, and he's a country cousin, if I can say that, because he's both ICU and pulmonology, which is something I'm also qualified in, and he will be also contributing very strongly to what we are going to talk about today. And this is me, Ravi Mehta. I am also pulmonary and critical care, originally trained out of India and the US, and currently in Bangalore. And we have also seen our share, unfortunately, no pride in that statement of COVID-19, which helps us to add to today's discussion. So with this background, we'll be taking on some very provocative aspects. And I'm very happy to have such an august panel who can really give us everything, the background, perspectives, their own experience, which is important too, the data and literature-based sprinkling which we want, and futuristic stuff. So with this, we will start our major questions which we've raised in the time we have. For the audience, this is going to be around 40-45 minutes, plus or minus 5 minutes, depending on the interest we generate in the questions we have. And then we'll try and have a summary statement so that we take home some important messages for the future as this pandemic continues to rage its expressions worldwide. So I start with what is going on worldwide. The story started, late December 2019, went all the way through 2020. We're sitting in the second half of 2021, and we seem to be playing this worldwide dance. The planes have come to a halt, but COVID-19 is moving irrespective. So worldwide patterns, what's going on? Why is it going on this way? Did we predict this? What is the story of variants, which seems to be the perpetuating issue? And any perspectives which will help us to panoramically understand this from a past perspective so as to weigh on the future. I lean on Dr. Barry Zingman in this sort of wide nebulous question to give us his inputs.
Thank you, everybody, for joining in. I'm honored to be part of this distinguished panel. Thank you to the organizers, and thank you for that nebulous question. So it wasn't actually a nebulous question. So right now the state of COVID worldwide is that we are in a surge worldwide. We're up to about 650,000 cases being diagnosed per day, almost 10,000 deaths worldwide per day. And largely, the pandemic right now is sitting right where I am. It is largely being driven worldwide by the numbers in the United States and lesser so, but also in Europe. The Latin America, South America have decreased over time. Across Asia, the numbers are quite low now, particularly in Southeast Asia and China. There are hotspots in Australia and a little bit in the area around there, but is really being driven by the U.S. epidemic right now. And virtually all of these hotspots, it is being driven by the new Delta variant. The other variants have been largely replaced. The Delta variant is estimated to be at least twice as transmittable as earlier variants, and that seems to really be driving the epidemic.
Right. The whole question is that, Barry, when we look at what we went through, and it's very interesting to see worldwide panorama. We had our raging wave 2 in April, May, and towards some part of June. And retrospectively, it was Delta, and maybe if you want to make it more complex, Delta Plus, which is another fancy name for, I think, the variants and putting more numbers to the right of the variants. In such a situation, we now feel that the US is seeing the tail part of it, when actually you guys got the pandemic much before us when we look at wave 1 and so on. How do you factor this in, and where do you see this going?
Well, okay. I think one of the bases for why we're seeing the kind of waves that we are is one, that the virus is very mutatable. It's easily mutatable. And with so many millions of people being infected at a time, this small mutations are occurring frequently. And with such a large infected population, these mutated viruses are spreading quickly. The second reason, besides for the high risk of mutations for this particular virus, is that we have so many unvaccinated people. And if it wasn't for the fact that we have so many unvaccinated people, mutations wouldn't be developing. These mutated viruses would not be spreading as well. We know right now that, and this is maybe for later on, we know that right now that most of the vaccines that are available are quite effective. And so these surges that we're seeing are the result of an unfortunate lack of vaccination across the world.
Right. Shifting the whole perspective to Russia, Dr. Alaiva, what are your thoughts on this particular aspect? So let's now understand, now that we know that this is going round and we have waves on waves coming, and we always hear that maybe somewhere in Iran and all, they're talking 4th wave and 5th wave. We have enough and more of on our hands that we tend to figure out when is the wave going to hit our particular countries. Let's get down to what we can do about it. The million-dollar question is current and future therapeutics. Just to give a brief background, we went through a repurposing like crazy. We threw the kitchen sink at our patients. And this was evolutionary as you look at the enormity of this pandemic. So we started off with the infamous drug hydroxychloroquine, which is, I think, a treatise by itself. And then we've gone through a whole generation of drugs in different countries, depending on data, perspectives, faith, approvals, and so on. To cut a long story short, what is the current and futuristic therapeutics now that we know that we have to live with this and figure out what is the right way to deal with this? Dr. Joyce?
Yes, thank you for the invitation. It's glad for me to stay here. About the new therapeutics for COVID, I'm not sure if we have an effective drug, actually, because we tried to use hydroxychloroquine in the beginning of the epidemic, and it's not working very well. And other medications, as ivermectin or colchicine, don't show the good results. So I think that the most important understand about the disease development. The first phase of the diseases, we don't have any medications indeed. Maybe remdesivir, but the remdesivir don't show us a great result about the mortality. And the second phase, the corticoids is the most important to treat and control the disease, the inflammation. So I think that the most important is the vaccination. The vaccination show us the impact in the decrease the diseases. It's the UCIs are going to be empty since we started the vaccination in São Paulo, Brazil. No. It's because we work in here, but in the other states we can't see the same thing. But we have a irregular vaccination in the country, so some states in Brazil decrease, of course, the cases, but it's not so sharply than São Paulo.
Okay, Dr. Isola, your thoughts on this, adding to Dr. what Justi is saying?
Thank you for the invitation. I'm very glad to be here with you today. I'm from São Paulo, also from Brazil. And I will agree completely with Dr. Justi. And I want to add about the current therapeutics, not drugs, but other things like mechanical ventilation. It's my area of expertise. We are still understanding completely the CARDS, the COVID ARDS, and its mechanisms. And we need to understand better the benefits of non-invasive ventilation, CNAF, catheter nasal high flow, and other like spontaneous prone. Recently, today, we had a paper that was published and we are trying to understand this evidence. We had a very serious problem in Brazil because our country is very heterogeneous, and we had current doctors, intensivists, that even them had problems with mechanical ventilations and the difficulties to conduct this ARDS serious patients, and we had to train those people, and we had a lot of courses and a lot of actions. Our society, AMIB, has a lot of trainings, and in our hospitals that I am responsible, we had a lot of courses to improve these mechanical ventilation concepts like driving pressure, respiratory rate, mechanical power, and a lot of things that could change the outcome of these patients. We can discuss a lot of aspects because we have a problem like the common people, patients are afraid to be intubated. They don't want to be intubated because the result is 80% of mortality. This is absurd. So we need to change this and explain to the society. I don't know in your country, but we have a serious political problem here with politicization of the pandemic and a lot of fake news. And we had to prejudice our patients and our doctors and our healthcare professionals. We had a hard work to put the things on trail and see what is the real evidence and what's correct. I think we learned that innovation, it's much important. We had people searching for the silver bullet of the mechanical ventilation or support or treatment in many aspects, but unfortunately, we didn't find it yet. So problem is that many try to apply this silver bullet without it being a real silver bullet. So this is a thing that we are today, and we wait for the future therapeutics about drugs and about support at all. I think that's important to be said. Thank you.
Thank you. And Dr. Zingman, since you were one of the primary authors of the remdesivir study, can we ask you to weigh on remdesivir at the same time monoclonal antibodies, which have really picked up and they're also available in our country at least? One of them.
Sure, absolutely. Yeah, thanks. I completely agree with the comments of Drs. Justi and Isola. I'd just like to expand a little bit further as well. I do think that one of the problems with studies, some of the studies to date, has been the mixture of populations in those studies, some of whom might be expected to work if the drug worked really well, but others would never have been expected to have worked. For example, you can't expect an antiviral to work if you're well into the inflammatory phase. You can't expect an anti-inflammatory medicine to work if you're in the first 2 or 3 days where viral replication is driving the infection. So some of what we've seen with certain of the drugs that have been shown to work, like remdesivir, like steroids, when we have to separate out subgroups in whom they do work and in whom they don't work, instead of mixing them all together, because that makes them seem less useful than they actually are if we properly target from what we've learned who they work for. So it's really quite clear that if we can use an effective antiviral in people who are progressing and are early, that it will work. An effective antiviral like remdesivir will decrease the rate of progression to mechanical ventilation, and in people on low flow oxygen, it will decrease mortality. But if we start mixing in people who are moved to the higher inflammation stages, then the numbers get all mixed in together, and it seems like it's not working. So we have to, as the expression goes, we shouldn't be throwing out the baby with the bathwater. That we know that these therapies actually do work in some circumstances. We shouldn't negate them because they don't work in all. And one example as well is steroids. The dexamethasone seems to worsen outcomes if you give it too early, because you're probably in the antiviral phase. So we're not throwing out dexamethasone because of that. We're just not giving it at the very early phases. Okay, so let me just say, so there is a great need for further therapies that might be antiviral targeted at people very early. There is the potential that oral antivirals may be able to be given very early after the onset of symptoms. There's the potential that they can be easy to give, inexpensive, low toxicity, and could prevent hospitalization and death. We are seeing that with monoclonal antibodies, that they can very significantly decrease hospitalization rates. And if they were given to a larger number of people, maybe they would decrease death as well, but we haven't been able to show that yet. But monoclonal antibodies are not a worldwide solution. They are definitely not a worldwide solution. They're too expensive. They're too difficult to give. So they're not a worldwide solution. They are a temporary solution, in my opinion. I do think that there is a significant potential for oral antivirals, and there are studies going on of potential agents like molnupiravir. There's a promising Pfizer protease inhibitor, and there are others that are being evaluated. Now, one thing that really hasn't been shown to work, unfortunately, has been convalescent plasma. How many tens of millions of people have received convalescent plasma? And unfortunately, it's been very difficult to show that it works. Whether or not it's because the people getting it are too late or because it's just not potent enough, convalescent plasma has not fulfilled its hope, and how easy it is to get and how relatively inexpensive. It just hasn't fulfilled the hope. And also, in part, that could also be because you're taking antibodies from before and trying to give them now, and so the virus has changed. So that's another aspect in this. And one of the reasons why I bring up the antivirals is because they are less susceptible to mutations from the virus, as opposed to the monoclonals, which are very susceptible to the changing mutations. And then let me just point out one last thing, and then I'll stop talking. There has been some interesting small publications about inhaled corticosteroids, in people who are outpatients, and inhaled budesonide was published in the Lancet, and that's an interesting possibility, because it may be that certain outpatients have already gone into an inflammatory phase, not as bad that requires them to be hospitalized, but some of them in the recent Lancet study, the average duration of symptoms was in the 7 to 10 day range. So some of those people may already be moving into an inflammatory phase, mild, and budesonide seemed to help them. So we need a lot more studies on this, but I think there actually are a number of promising possibilities.
Thank you so much. I think we move over to the next aspect of the discussion. Just as a background, we've all struggled with outcomes. We've really struggled with outcomes. And Dr. Isola mentioned this, the 80% mortality on ventilator, the difficulty in taking a decision when to ventilate. The whole worldwide community has struggled with it. The ability to put people on ventilators when you know that you can't manage them very well with dwindling resources and so on. So that comes down to the holy grail of outcomes, of outcomes in the holy grail, which is especially mortality. What can we do now with all the lessons learned to target good outcomes, especially mortality? I'll ask Dr. Aliva to first weigh in on this and then take Dr. Zingman's opinion after that. Dr. Aliva?
In fact, 2 years ago, we faced a very serious problem with COVID. And if to talk about the mortality, I strongly believe, and I'm talking from a position of a cardiologist, I strongly believe we have to go to the risk assessment, because I would speak about Russia, the problem to adequate stratification, who is severe, who is in critical phase of COVID, who is in moderate, because only the adequate risk stratification may help us to choose an adequate treatment. Continuing the story about the current therapeutic approaches, for example, interleukin-6 receptor blockers, we were talking about monoclonal antibodies. If we look on the guidelines of WHO, and the update was published just on 6th July of 2021, we can see that at the moment, this class showed decrease of mortality based on 30 randomized trials and more than 10,000 patients who were enrolled there. Here, I would like to fully support the statement that Dr. Zingman was speaking about, that we for sure have to separate groups of patients, because fear of patients, lack of probably experience of doctors provide us with the situation when moderate cases, doctors start the treatment with interleukin receptor blockers, with anticoagulants, and for sure it doesn't show its efficacy. But if to talk about the severe cases, about adequate risk stratification, I believe that interleukin-6 receptor blockers could decrease mortality in severe cases. If to talk about Russia, we have quite good experience of using systematic corticosteroids, but for sure it has to be also used in an appropriate cases and adequate doses, as it's written in guidelines, 6 milligrams around 7-10 days, not less. So all these approaches. And especially in the beginning of the COVID story, there were many attempts to do CT scanning to all patients. Now we know for the adequate stratification, the first line, oxygenation. So based only on this parameter, if it is less than 90%, it could be already a very good marker of severity of the disease. Adequate risk stratification leads to adequate treatment and decrease of the mortality. I think like this.
Well, thank you. Dr. Zingman, if I could pin you down, focused what things actually would now improve mortality, and we're not talking only medications, we're talking systems and how they tackle COVID-19. If you could throw some more light besides the interesting points raised by Dr. Aliva.
Okay, thank you. So we should not talk about decreasing mortality without talking about vaccinations. Already, vaccinations have been shown to decrease mortality because if you can decrease COVID-19, and particularly if you can decrease serious cases and hospitalization, you stop mortality. You greatly reduce mortality from COVID-19. So vaccination has to be our first strategy. It absolutely has to be, the priority worldwide. Of course, absolutely decreases mortality. That is very clear. Okay, now let me just add something to what Dr. Aliva said. I think as well, we are saying that adding anti-inflammatory therapies onto dexamethasone may help. Adding IL-6 inhibitors, adding baricitinib, a JAK inhibitor, may help. So I think that also raises whether or not, and I think she was alluding to as well, it raises whether or not the dexamethasone dose is the right one. 6 milligrams may not be the right dose in everybody. There may be others who need more of this inexpensive, widely available medicine, as opposed to the very expensive, very unavailable IL-6 inhibitors and JAK inhibitors. So we are at times using 12 milligrams of dexamethasone or even 20 milligrams of dexamethasone in particularly sick patients. So I think that is an area that may further help mortality, as well as further help us manage the people at high risk of mortality. Okay, now, and in terms of other aspects, then, you know, another aspect is anticoagulation, and you know, it's been demonstrated that anticoagulation for people who are seriously ill should be only at a therapeutic level, but if people who are less seriously ill in the hospital on low flow oxygen, they may benefit from therapeutic anticoagulation, and there are some trends towards mortality benefit in them as well. We need, you know, really further information on this, but we are often using therapeutic anticoagulation early in the hospitalization, but then cutting back to prophylactic anticoagulation if they get much sicker, because the risks of bleeding go up then, in particular. And then other things are just, you know, I don't have any doubt that one of the reasons why we had such high mortalities early in the pandemic was because of late diagnosis. So, right, we didn't have tests available, we didn't recognize the illness, people were home for a week or 2 or 3 before they finally came in and got anything. So we, you know, we continue, unfortunately, to have to ramp up diagnosis and the ability of people to access those diagnostic tests early on, so that they can know that they have it, they can get appropriate medical therapies if they need it, so we can decrease transmission to their household contacts, in the community. That as well, you know, early recognition, early diagnosis will also help the mortality rate. I'll stop there.
Okay, so interesting aspects, and if I can add a few things to them right now, what we have also dwelt on frequently is the fact that the steroid story can never be done again easily. I don't think it's going to be easy to run a trial where we show that the steroids are useful in what dose, and is there a subset which may or may not benefit. Attempts to show earlier that baricitinib may be used instead of steroids were not very, did not have a lot of traction. The 2-3 things we found with steroids was the following. A, the dosage. I mean, if we ever talk of titrated inflammation as a concept we pick up from other parts in pulmonology especially, and Dr. Isola can add to this, we have no way of titrating inflammation in COVID-19. A cookie cutter dose was thrown at everybody with a mortality benefit which was tangible more in the mechanically ventilated population, and we went gung-ho with that. But somehow when we sit over there and scratch our heads and say that at the end 22% still died even in recovery, and probably more in some other studies, then there is a problem with either the dose, the duration, or the fact is there is no customized COVID medication going on. One thought which has frequently crossed your mind. Second thing is the very fact that you certify the cascading inflammatory pathway. IL-6 comes as down the line or as a subset of that. And you find that there is a role of, say, tocilizumab, sarilumab, or for that matter, baricitinib or tofacitinib. It means that did you use the right dose of steroid, or were you actually leaving some sort of incomplete pathway which is either complemented or supplemented by these agents? So a lot of these questions came up. Lastly, no drug is without its detriment. We have been carrying the sword of Damocles on our head with steroids, and I use this expression very strongly because we have seen infections which never go away. The patients which go on ventilator, they basically get infested in countries like ours with the resistant Klebsiellas, Acinetobacters. We are now talking mucormycosis in our country with 45,000 cases, what we call the epidemic after the pandemic, which has been a nightmare. Enough and more discussion can happen on why steroid doses and on. But certainly it leaves with the fact that there is a customized component to the field, which is probably more important targeting outcomes, in addition to leaving a guideline with just A, B, C, and D. So clearly from the kitchen sink, we've come down to fewer components. But at the same time, the titration of those fewer components in every COVID patient to give outcomes seems to be the challenge we face as these patients will come in the future waves. Any thoughts on this sort of apology, a little more detailed story which I have built up? Anybody?
I mean, I'll just say I think that was part of what I was saying as well. Is that yeah, we need a lot more individualization of anti-inflammatory as well as antiviral therapies. I mean, all of these we to the extent that we can differentiate people based on characteristics, it will help. We have used CRP cutoffs for people on low flow oxygen to decide whether or not they need steroids or not. We found that a CRP, at least using our measurements, should be 15 or higher if using our measurement. And if the CRP is much lower, steroids really don't seem to add that much of a benefit. We would benefit from having those kinds of markers better established to know, as you just said.
Right. So lovely. So let's go on to the next aspect. Crunch, let's get down to where it really matters. What have we learned from the 2 waves, or more? It looks like people have more waves than that. Are there lessons which are really piercing? And I don't mind expert opinions or individualistic opinions. Dr. Jewishti, what would be your take on this? Somebody who's been at the front line with infectious disease. What would you leave with the audience?
Yeah, I think the most important learning is the diagnosis. No, when the diagnosis is early, we can do more for the patients. I think this is very important. And the situation about the mechanical ventilation or the ventilation support is changed a lot since the beginning of the pandemic. And I think at this moment we can manage better the oxygen therapy and corticoid therapy. But I think, in my opinion, I think it's most important is the antibiotic use. We at the beginning the pandemic, we use a lot of antibiotics, and this is it's dangerous because in Brazil specifically, I don't know in other countries, all the physicians started azithromycin in the beginning the diseases, and this use of azithromycin impact in the resistance of Acinetobacter. So when the patient go to the hospital, they have a hard situation about the antibiotic resistance, and this is a very difficult to change because we don't have a lot of drugs to resistant bacteria or Acinetobacter and Pseudomonas, and this is very difficult. So I think we learn about that. We can't use the antibiotics unless it is very, very necessary. And the diagnosis must be early, and we must be aggressive to treat with corticoids and the oxygen supply. I think is the more important lessons for me.
Excellent, thank you, Dr. Isola.
I agree completely with Dr. Jewishti and Dr. Zingman, and I want to add that what we learned in our reality is it's possible to quickly organize teams to education of healthcare professionals during the crisis. We had a good experience with this. We tried to educate doctors that were not intensivists to go to the first line and to take care of these patients in a proper way. In the first months of the pandemic, we had a problem with personal protecting equipments here. A lot of doubts. People don't know how to use the PPEs, and now this is learned. I think this is important. People are less stressed to work with COVID-19 patients. As I said before, many doctors had the problem with mechanical ventilation properly conducted, and we had to train them. This is a very learned thing. And now we learn that we do not earlier the intubation, but we not do the later intubation also. This is a challenge with the cases, with the difficult cases, to take the decision to intubate the patient. we learn now to do a safe position, a safe prone position process. Many hospitals never did a prone position before, and we now have this. I think this is a common knowledge in Brazil now. The use of extracorporeal membrane oxygenation now is more spread. It's not common, but we have more hospitals doing it properly. And the rationale of the oxygen, the use of oxygen was very important. In Manaus, Amazon, we had a serious problem with oxygen, and other parts of Brazil also. So we need to put the goals of oxygenation and teach again the doctors that we don't need to keep patients with 100 or 900% of oxygen saturation. Above 90 is okay. Perhaps between 90 and 94% is okay. So use the oxygen with more wisdom. And antibiotics, Dr. Giusti was said, to the secondary infections, rational use of antibiotics was, I think we learned a bit. We need to learn more about it. Many places have problems with antibiotics yet. I think what I think that we need to improve: questions about sedation, weaning, quality of life, long COVID, rehabilitation. There's much important. There are a lot of patients that survived to COVID and has now a lot of disease, other disease that is overloading the healthcare system, and we need to deal with that now. We have learned to manage stress to the team, burnout, and resources during crisis. This is a challenge, and I think we learned a bit about it in Brazil. Cybergogy was accelerated, and the culture has changed. Now we are here today using cybergogy to do Congress and to put all together to exchange the knowledge and improve that. Dissemination of true knowledge is important too. And we're joining forces to avoid fake news. And unfortunately, I think that we'll have future waves, perhaps just in COVID or other diseases, other viruses in the future, and we need to use this knowledge. And I think the availability of PPEs and basic resources is a very precious lesson that we need to be better prepared to future challenges. Thank you.
I think that's very comprehensive. Can I ask you guys a frank question? Do you have any sort of a debriefing or a white paper which comes out of after these waves to try and figure out what to do for the next wave as a hospital, a city, a state, or a country? Is it happening often or adequately so as to give a feeling of better preparation for the next onslaught? Dr. Isola?
Well, I don't have a paper about it, but I think we need to put all the knowledge together to spread this and try to obtain better results. This is important to create a new culture about it, and people are less afraid to treat these patients. We have a serious problem with personal, less of personal here due to being ill with COVID and too afraid to be ill. And so burnout, and they didn't yet to the job, they didn't went to the job, a lot of problems. So it's a very good idea of you, and I agree with you.
Right. Other countries, Dr. Alaiba or Dr. Zingman, do you actually have that? Because I'll be very confessional. I don't see enough of debriefing happening in most of our setups, so as to give us a strong feeling about the next wave in all the aspects which my co-panelists have so very well covered. Do you have that in your countries?
Oh, in the U.S. we have ongoing revisions of our guidelines from the NIH and the Infectious Disease Society of America. Those are being updated about every week or two. I think that's what we primarily rely on is these national guidelines committees, which are excellent, and the turnaround after a new publication is very quick, and I think their guidelines are comprehensive and reasonable. I also think that the Infectious Disease Society of America has a COVID learning portal, which people all over the world really could find very, very helpful, because it also incorporates some of the newest information, and as a learning center, basically a learning center for new information to present. So the Infectious Disease Society COVID, I'm forgetting the exact terminology for it, but their learning network is a fantastic resource for people around the world. And let me just add one other thing, which is into lessons that we've learned. I think a highly charged, politically charged, but important lesson we've learned is on the role of masking and mandatory social distancing and indoor precautions. We have really very clearly learned when rates in the community are significant, or if they're going up, that masking needs to be increased, that that indoor activities needs to be decreased, that ventilation needs to be increased. And we need to start these, if we have let them up, we need to start them right at the first signs of rates going up, rates of new positive tests, rates of hospitalization. We have to start them right there to be able to stop that new cycle as early as possible. Because if we wait and wait and wait, just more and more people are exponentially getting infected. So masking is critically important. And I think just because a lot of people hate masking, we wait too long to start it again.
Right, interesting. And the other few lessons, I think, which we all learned in our setups, again, it's very country specific and speaks volumes of a global nature of such a meeting, is that we learned that the tail end of COVID can include horrors such as the fungal infections we have been seeing. And I'm coming back to that point, that if we use rampantly steroids and steroids went on for too long, and then we have all the immunomodulators over there, and of course, not to mention the antibiotics Dr. Joysti mentioned, they seem to be having a peculiar predilection to having steroids. Now, we would like to blame the Delta variant, and we are still figuring out what actually caused the mucormycosis outbreak. But we know from other parts of the world, since Delta is going to other parts of the world, is it Delta or the therapeutics which actually leaves these patients barely recovering from one onslaught and go through multiple surgeries and medications of a very horrific nature? So multiple lessons, and I reiterate the need to have both societies, individual organizations, your own ecosystems to debrief and try and find solutions, both at a guideline level and at a local level. I think in the interest of time, I'll cover two more important questions. Dr. Zingman mentioned vaccination. No discussion on COVID can be ever not actually monopolized by vaccination at this point. And in a few minutes, I would lean on my two infectious disease experts over here, the long and the short of it, including the latest kid on the block, the booster, which the US has so interestingly and provocatively put in the global public space, and we are all now scratching our heads wondering what to think when it comes to this particular additional point. Dr. Zingman, the floor is yours, followed by Dr. Joysti.
I mean, I think there's many different ways to approach this question. So thank you for the question. But there are many different ways to approach it. We clearly have identified a number of effective vaccines around the world. I think we've also clearly started to realize that some of them are less effective than others. Some of them are less effective against the original strain, it turns out, but particularly some of them are less effective against the mutated strains. So some of them are emerging as better, some of them not as great. That doesn't mean that people shouldn't get the less good ones because it's better than nothing. But there, I think over time, some of them are emerging as better. I think we're also learning that some of the newer technologies for vaccines may have some downsides as well. So mRNA vaccines was a brand new technology. We had never used them before. I actually kind of always suspected that they might be really, really strong up front and then start to wear off because of their mechanism. Where you're just giving people a burst of spike protein in the first week and then nothing after that. So I've actually been kind of waiting and wondering whether or not the adenovirus vector vaccines or the protein boosted vaccines and others might turn out to be less effective right away, but have greater durability. And I think we may be starting to see some of that. That it may be that some of the others have greater durability. So we will see. I think it's been that most of the vaccines do retain quite good activity against Delta. So that's been that's been nice to see that there's particularly good protection against serious disease and hospitalization. Although infection, they all fall down on infection rates, and therefore there's transmission, even though you've gotten these vaccines. And I think that's where boosters are coming up. So the discussion about boosters is coming up in two different areas. One is there are certain people who would not have responded well to the vaccine to begin with. The immunocompromised patient. They may remain highly susceptible at greater rates. They may need a booster to be able to get them to the level of protection that somebody not immunocompromised needed. I don't really think that there should be any controversy about that, frankly, because they probably were never well protected at all. They're almost like they were unvaccinated. I think a second issue is second population is if it's just been a period of time and your immunity isn't as good. I think there it's a matter of supply and demand. I think or a matter of supply. I think if you have supply, we are starting to see that some of the vaccines wear off. We are starting to see Moderna and Pfizer presented data showing that in particular, what seems to wear off is immunity against Delta. So Delta immunity in particular, immunity against some of the variants really seems to decrease over the 4 to 6 month time frame. And so that's why some places are considering a booster. It's because of Delta, and because in a place like the United States where we're seeing 150,000 cases a day right now. That's like India a few months ago. We want to do everything possible to try to stop this outbreak right now. And so that's where boosters come in, at least in the United States. We're in the midst of a terrible outbreak right now.
Very interesting. I think you've given a lot of insights. Dr. Juisti, your take on this? Both vaccines, whatever special takes you can talk in addition to the extensive information, plus your take on boosters.
I'm sorry. In Brazil, we applied the four types of vaccines: CoronaVac and AstraZeneca and Pfizer and Janssen. But the most of the people received the CoronaVac. It's old, not older, but it's use technology, and since that's good, and we don't have data about this efficacy about to the Delta. But appears, I'm not sure, maybe we need a booster sometime. I don't know when. Because it's not clear. The Delta is not is increasing in Brazil, but it's not very increase at this moment. It's not it's only a concern. It's not a problem. But I think maybe we can discuss about the booster about it. I don't know what maybe the health professionals, maybe the others. I'm not sure, but I think it's important. The impact of the vaccine is strong, and all the vaccines are good for us, I think, because we have in April, I think we have 4,000 deaths per day. It's very complicated, no? And now we have around 800 with the vaccines. So I think it's important. It don't care about how which vaccine is that. I think all of them, and the booster. I think in the future we be study the data about the booster. In my opinion, for the healthy professionals, the most important, and the immunocompromised other groups.
Right. Thank you very much. I think now we head towards the end of the session. I would just like a few lines, and this is the general stuff we put over there as a thought process, innovations, futuristic aspects of the way ahead. A few lines for each one of you, and then we will conclude the session. We'll start with Dr. Alaiva.
Thank you so much. I think we learned many things during last couple of years, and many things we have to learn in the future. First of all, I strongly believe that the healthcare system has to be very flexible and to be ready to react very active in the times like happened a couple of years ago with the COVID. Returning to the question of lessons we learned, I need to say that we started to develop our telemedicine system, because in the beginning, when many centers, very high qualified profile centers like our cardiac center had to work with COVID patients, many our patients with cardiac diseases got the progression of the disease due to the lack of understanding how to proceed with it. So at the moment when we started telemedicine consultations, we saw the positive trend, and I think that healthcare organization has to all levels have to work all together. And for sure, vaccination. I didn't have much time to talk about this. As you know, we use Sputnik 5 in the territory of Russia, but it is not a question of what to use. I strongly believe that we have to be vaccinated, and that's the only way to decrease mortality and to overcome this pandemic. Thank you so much.
I agree with Dr. Alieva. I think the telemedicine is innovation, and the vaccination, I think it is the most important.
Thank you. Dr. Isola?
Thank you very much.
I agree with the previous panelists at all. And I want just to add that we need to be better to the future in educate people and to spread the correct information. This is very important to get the better effective results. Of course, we need drugs, we need news, innovation, but we need to use it properly and spread the knowledge about to everyone. This is important. This has prejudiced us in Brazil. We had difficult to capillarize all the information to the distant places and the less equipped hospitals. So this is important for us, and this is what I want to add. Thank you again for the invitation for me.
Thank you. Dr. Zingman, your take on where are we headed?
The other panelists said, a lot of wonderful things, which I completely agree with. Let me just raise one way to think about at least one aspect of this. I think many of us are aware that when there's a highly abnormal lab test that comes back, we get called about it. We call it a critical value, right? Critical value gets acted upon immediately. I think that we need to be taking that approach to the vaccination rate in countries around the world. It should be a critical value to all of us if the vaccination rate in a certain country is 1% or 0. I mean, that has to be viewed by all of us as being critically important. We have to do enough to be able to get buy-in, to work with countries that are having struggles in this, to give vaccines out. We have to view very low vaccination rates as a critical emergency to intervene in as soon as possible. This pandemic has shown us how much we are one world, and we are just going to get Lambda and Iota and so many other variants if we don't truly figure out how to work as one world.
Right. Extremely interesting. And I think to try and wind up the session today, we'll first of all try and summarize what we've talked about. The idea was that we have a excellent international, widely spread quadri-continent group, which will enlighten us on so many aspects. And what Dr. Zingman brought about as the last point is actually the idea of trying to do this, that we have looked at globalization for everything else, movement, trade, economy, medicine, and so many other areas, and war, unfortunately, too. But we need to look at COVID very, very differently. It seems to be that as the earth is spinning, COVID seems to be spinning with it. So a COVID cooperative collaboration at all levels, and at this point, the top of the pyramid being vaccination seems to be the way to go. Otherwise, it's going to be just one country dwindling, another country taking off. It's like a relay race of COVID, which the virus seems to be leading at a speed greater than the fastest 100-meter dash that we have seen. So this is one of the main messages coming out. Meanwhile, on the concrete front, what did we discuss today? Summarizing very quickly, we started with the fact that what we just touched upon, that it's a worldwide problem. It is just going staggering months in country after country, and that is why future waves are being looked at very concerningly and very apprehensively about most countries in the world. The driving factor for these waves seem to be the variance part of it, which is a function of how many vulnerable targets are there, which is a function of vaccination and native infection, and that's what's driving the mutant story, which is very, very concerning. In a nutshell, that tells us why we're suffering from this whole entity with current understanding. We then dwelt on therapeutics, where we talked to the fact that from the kitchen sink, we've come down to focus therapeutics. Obviously, we can't discuss everything at length, but we talked of some core areas like antivirus, which still have a role, as Dr. Zingman pointed out, in the early viremic phase of the disease. Let's understand that remdesivir has a role, albeit localized, in the first 9 to 10 days with the typical subset of low-flow oxygen to prevent deterioration. And clearly, monoclonal antibodies, though suffering from equitable and accessibility issues, have data to back them when it comes to preventing worsening, as well as interesting aspects of inhaled budesonide as a easily available modality. And at the same time, we discuss anti-inflammatory over there with a spot of anticoagulation, which has done a yo-yo from preventive to intermediate to therapeutic, and largely hovering between preventive and focused therapeutic. We went on to targeting outcomes, very, very important. I mean, all these things were reiterated right from early detection to risk assessment to then looking at focused drugs, which have made it to the guideline stage in terms of impacting both either at least outcomes such as morbidity or hospital stay or cutting short the disease or mortality. And this was interestingly brought out by the panel. One of the most interesting things I personally found is the lessons you guys pointed out, and right from my panelists talking of early detection, diagnosis, how to marshal the systems, lovely points by Dr. Isola also about whom to treat, how to treat, what was done in your different countries, and in addition to core issues in critical care, looking at the sequelae of COVID and so on. So it's a massive analysis, more than a single field taking up so many areas has never been seen before, and that's why we need to all marshal our systems, city, state, country, all of them together to try and do a better job next time. We tried to wind up with vaccines, and we asked the core question, because we're not going to cover all of vaccination, where Dr. Zingman, I think true to his heart and coming right from his lung, if I may say that as a pulmonologist also, mentioned the fact that it has to be a global hat over there. And we like the term of critical vaccination threshold or which you brought out over there. And I added to that in terms of the fact that globalization has never been more imperative as the word vaccination. So I think the same breath both are important if we plan to have less webinars like this on such a entity which has turned our lives upside down and made the earth rotate in the wrong direction. We ended with the way we're going ahead, and all our panelists contributed to that very interestingly with these aspects put into perspective. And so this is what we have talked in the last 45 minutes to 1 hour. On a personal note, thank you. You have both jogged the mind, increased knowledge, as well as put things into perspective. I would like to thank all my august panelists for weighing in both and experience, knowledge, as well as putting it into interesting language. Dr. Zingman, Dr. Alaiva, Dr. Juisti, and Dr. Isola. If there is any final comments you would like to make, I welcome at this point. Otherwise, it has been lovely to interact with you on this session. And I will, after your comments, close the session.
Thank you very much.
Thank you very much.
I think that's a lovely way to end.
Thank you very much.
Thank you so much. We thank the platform which has called us. This is the Association of Physicians of India and the Omniqueris platform which has brought us here. And I do thank my panelists for this varied timing which we all have logged on. I think at the end of it, will realize it's around 8 o'clock, 7:30 India time, 7:30 p.m. India time. It has been amazing to listen to these insights. I wish all of you the best in managing the pandemic, and I think holding hands together with these thoughts, if it becomes a reality, will be the beginning of the light at the end of the tunnel, which sees us getting over this and moving on to relatively normal lives. Thank you very much, and have a lovely day, all of you.
Thank you.
you.
Thank you very much.
Thank you.
Bye.